My name is Jerry Williams. I am the founder and president of Myositis Support and Understanding, and I'm also a patient living with dermatomyositis, refractory dermatomyositis. Today, joining me from MSU are MSU's Director of Patient-Centered Research and Vice President, Lynn Wilson, and our Chief Science Officer, Manuel Lubinas, and they'll be helping me moderate the session today. So we're here today because we know that there's a lot of questions about Ig therapy, IVIG, sub-Q Ig, side effects, timing, methods, insurance. So we talked to one of our beautiful sponsors, CSI Pharmacy, and they so graciously agreed to come join us today and answer your questions. So joining us today from CSI Pharmacy for this wonderful webinar, we have James Sheets, who is a PharmD, and he is also the, an IgCP, and he'll explain what that means. But he's also the founder and CEO of CSI Pharmacy. We have Roxanne Marlar, who is the nurse, a VP of nursing at CSI Pharmacy. And we have Michelle Vogel, who many of you know. Michelle is just a wonderful person who puts a lot of information out there for myositis patients. She's the Vice President of Patient Advocacy and Industry Relations. Welcome, James, Roxanne, and Michelle. And we also have two patient experts to answer your questions from the patient perspective. We have Melissa Gilbert, who is living with refractory dermatomyositis. And we have Hopfauf, who is living with immune-mediated necrotizing myopathy. We're going to start with a presentation that James is going to lead that will help us understand more about Ig therapy, and then we will take questions. So, James, welcome.
Thank you, Jerry. Hello, everybody. Excited to be here with you, and I always appreciate the invitation from our friends at MSU. I can tell you that we love to talk about Ig therapy at CSI Pharmacy. I am a pharmacist. As Jerry mentioned, we have Roxanne, who is an infusion nurse. So she's been there in the home with many patients, probably some that are on this call, either training them on self-administration of Ig or administering Ig. And she, of course, manages our nurses and clinical services. And then we have Michelle, who is our patient advocacy department, and really needs no introduction. Really grateful for her for introducing me to patient communities several years ago when she first joined the family. And we love being a part of this community. So again, thank you for inviting us. I think we'll have a great panel because we have someone from pharmacy, nursing, advocacy, and then patient perspective. So we got it pretty well covered here. And so hopefully, if you have some questions, we can to get you a good answer and at least get you going in the right direction. So we're going to talk about immune globulin therapy. If you want to go to the next slide for us, Jerry. And this is going to be a really quick overview. I've been asked to do it in 15 minutes, preferably less. So we're going to try to keep to that timeline. And the idea is just any of you who need a summary or some understanding, like, okay, well, what is Ig therapy? To get that laid out first, and then we'll go straight to the questions, which can be over anything, as Jerry said, anything from insurance coverage to nursing side effects, what's the differences in IV, sub-Q, whatever questions you have. But to get started, when we talk about Ig therapy, it's really immune globulin therapy. Okay, immune globulin is kind of a big fancy word, and it's real simple though, because we've all pretty much have heard of antibodies throughout our life. And immune globulins are just antibodies, and antibodies are just immune globulins. It's just a different way of saying it. And if you think about antibodies and what we've learned growing up, the immune system is an amazing, or can be an amazing system adaptation within the body to protect us. And as you all know, that it can also go haywire. But what antibodies do is our body's full of immune cells to help fight infection, whether it be viruses, bacteria, fungi, parasites, any of that. Our body is well equipped to deal with that, with different immune cells that come in and attack it and really gobble up all the bad guys. And antibodies are part of that system. They're made by one component of it that's called B cells. And what are so special about antibodies or immune globulins, again, the same thing, is that they're very specific to the exact enemy the body's protecting you from. And so if you receive the flu vaccine, your body reacts by building antibodies against that specific flu virus. And as we know with flu, it's very seasonal. So what protected you one year, you might need different type of antibodies the next year. But your body will make millions of these antibodies, and there's copies for each pathogen that we come into contact with. And so it's very specific. And what that does is when you are exposed to something that could be dangerous, like a virus or bacteria, those antibodies that recognize it are tagged to it. And when they tag themselves to it, they say to the rest of the immune system, here I am, come attack me specifically. I'm the bad guy. Don't waste your time looking at other cells. Just come and take care of me, gobble me up. And so they're, I think of them a little bit like smart missiles, you know, when they're GPS missiles, where they say, this is the bad guy, come get them. So that's what immune globulins are, including the immune globulins that are in your IVIG or SCIG. And where we get the IG therapy from, whether it's a bottle for you that have been on therapy, whether it's a vial of IVIG or sub-Q IG, is it's antibodies that come from people are donating their plasma. And they will donate their plasma in 10,000 different or more, really more, hundreds of thousands of different patients' donations are really combined, work together. There's a lot of safety involved, because I know that can be a concern, but so much safety in this process. And out of those plasma, they'll pull out a lot of really helpful things from the plasma. One of those things being immune globulins and or IgG, but the immune globulins are used to make the IG therapy. So that's really all it is. It's immune globulins coming or antibodies that come from different donors. And then IG therapy, now, this hasn't always been the case, but most of us will hear IVIG is what most commonly people will refer to, because it was kind of the original form, or the more recent original form. And that stands for intravenous immune globulins. And all it means is that we're going to give them into the vein directly IV. And then now we have subcutaneous IG or SCIG. And all that means is we're going to infuse it under the skin. Jerry, we can go into the next topic. So we talked about IG therapy. It's antibodies. It helps us fight off infections. Well, that sounds like a weird therapy to use for something like an autoimmune disorder. So what is the problem really with autoimmunity, whether it's one of the myositis that's immune-mediated or some other autoimmune disorder? What happens is that your body makes antibody copy. One of those, you make still tens of thousands of great antibodies that are doing their job, but there is a bad copy, if you will, or an antibody that's made that instead of being tagged to looking at a specific bacteria or virus or pathogen, instead it's attacking your muscle, or it's attacking some part of yourself. And so what it's doing is, that case, we call that an autoantibody. It's a bad copy. It's attacking itself instead of something foreign, and it's going to go tag normal healthy tissue, and your immune system is not going to realize that this is healthy. They're going to think this is something that we're supposed to attack, because this antibody is telling me I need to come attack it. And so it'll come do damage. And that's the basis of autoimmunity. There are autoimmune disorders that aren't mediated through antibodies. Most of the ones IG therapy are used for are what we call antibody mediated. And with myositis, if you look to the right on this slide, there is a large number, and this is just credit to all the great researchers and really physicians who are so dedicated to the field of inflammatory myopathies like myositis. And you can see all of these different autoantibodies have been identified. And many of you probably know, hey, I have JO1, or I'm anti-SRP. And you start to kind of classify your disease that way, because there's a lot we can learn from that. But these autoantibodies, like JO1 or anti-SRP, these are antibodies in your system that your body has made that are attacking your cells. And so these antibodies are not good like what you think of the other antibodies in your system. And that's what, again, autoimmune disorders are. And myositis is, there's a number of them that have been identified. Wonderful work going around that, where they can really determine a lot by just testing these biomarkers on how you should be treated, what's most effective, because maybe Ig is really effective for one, whereas another treatment may be more effective for one of the other antibodies. So they're kind of trying to tailor what starting regimens may need to look like for patients based on those. And I think you'll continue to see a lot of great research around that. So if we have these bad autoantibodies and Ig is nothing but antibodies, well, why does it help to give somebody antibodies if they don't really need them and they just have these bad antibodies part of their immune system? Well, it turns out that antibodies in the form of IgG or an IVIG, sub-Q Ig or Ig therapy do many wonderful things to help autoimmune disorders. Two of them that are the most simplest to understand is they neutralize these bad antibodies. So you get these antibodies from other people, these donors, they come in, they bind to these bad antibodies, and basically neutralize them so they can't go do damage. Another thing they do is they speed up the degradation or elimination of that bad antibody from your system, so you have lower levels of it. And that system's really being studied a lot. There's some new drugs that are looking at that specifically right now in myositis as well as other autoimmune disorders. But two different ways. They eliminate all antibodies, including the bad ones, plus they're replacing those with good ones from other people. But then they're also neutralizing those bad autoantibodies. And so that's the way it's really thought that Ig is effective. Let's go to the next slide. So, the differences real quick, like I said, this will be a quick overview between IVIG and SCIG. Again, IVIG is intravenous. It's just going through a vein. It's really the same thing, just made up a little bit differently than, or formulated a little bit differently than subcutaneous Ig, which is being given under the skin. In fact, some brands can be given either IV or sub-Q. Some can be given either way, the same vial of medicine. But some of the differences there, if you think about IVIG, it's a larger dose and it's being given every 3 to 4 weeks. Now, this does vary greatly depending on patients. It's very individualized. It may be 6 weeks for some patients, but in general, especially with myositis, we see a lot of larger doses giving every 4 weeks with IVIG. The infusions take longer. It's maybe once a month, but you have a nurse administering this in the home, and infusions can take 4 to 8 hours. I mean, sometimes they can be faster. There may be some that are lower doses that are 2 or 3 hours. Some patients, it may take 10 or 12. We've had those as well. And really the rate that we give it is based on how you tolerate it. And a good nurse, a good pharmacy is going to slowly titrate your rate up. They want to start you slow. And as long as you tolerate it, that's fine. They can get to a faster infusion. But if you do have symptoms, they need to stop back down to the rate that you weren't having symptoms. And from that point forward, we call that your individualized rate. So that's kind of how we determine how fast we give it. It's really based on how you tolerate it. It's really important to know, because if you are having symptoms, we'll talk about that in a minute. One of the most common side effects is headaches. Now, there is a number of side effects with IVIG. They're called systemic side effects because they're given right into a vein. They affect all types of systems and really are brought about by the effects of that Ig in your blood. And headaches are one of the most common that people complain of. Some of the more serious ones that you'll see is thromboembolism, which is clots. That's one that really scares people, is a risk of clotting. There's things you can do to lower that risk if you are prone to have more clots. Kidney disease is thought of, meaning really acute renal failure, meaning your kidneys are kind of malfunctioning. That one's really thought of, although it occurs a lot less than what it used to because of the formulations. And then several others that may occur from chills, fever, and a vast array of what we call systemic side effects. Now, not everybody's going to experience those. The serious ones are obviously fairly rare because it's a risk versus benefit, and there are things we can do to mitigate them. So that's important that you know those as well, or the pharmacy, physician, nursing that you work with knows that. Another thing that on this slide says effects wear off. Well, it's given monthly, so when it's given, you kind of get this high level and then it decreases over time. So a lot of patients will do really well after their infusion, and then 2 or 3 weeks in, they'll start saying, hey, I'm having some symptoms come back. And that's just because the level's fallen off and it's time for a new infusion. When you give it under the skin, there's some differences, okay? So it's typically, instead of once a month or every 3 to 4 weeks, it's given weekly or sometimes even twice a week. It could be every other week. Most commonly, it's weekly for myositis. The infusions, most people learn to give it themselves or have a caregiver administer it to them, and they can infuse it over 1.5 to 2 hours, once a week. And most side effects with sub-Q Ig are not the systemic side effects, but more local, like lumps under the skin, irritation around the injection site. There's also things we can do there to lower those risks. So it's important you understand that as well. And so that's kind of two of the major differences. And that sub-Q Ig dose, it takes the large dose we see with IVIG and just spreads it out over a longer period of time. So you're getting lower doses, which is one of the reasons why there's so many fewer side effects. And then in general, you kind of get the steady level because you're always maintaining it because you're getting a lower dose every week. So a lot of patients do not really complain of the effects wearing off as much as what they would with IVIG. So let's go to the next slide. How am I doing on time, Michelle? What time is that? I can't.
You don't have to rush, James.
Okay. All right. So, and I think we're almost done here anyway. So treating infusion reactions become important. I actually think it's a couple ways to look at this. In fact, if you look at our motto, CSI, there's within our fingerprint of our logo, a motto that says individualized therapies designed to be as unique as you. And what I mean by that really is there's ways that we can tailor your regimen to make it more likely that you do not experience side effects. We can't completely eliminate the risk, but there's some things that we can do. Some of the common things you'll see is pre-medicating with Tylenol, Advil, or Benadryl. Really, that's more, again, an IVIG thing as opposed to sub-Q Ig. Sometimes they pre-medicate, meaning 30 minutes before you take a Tylenol and an Advil. The two most important ones we're about to cover next, okay? Slow infusion rate. If you're having side effects, let's not give it so fast. Let's slow the rate if we can. And that is one of the most major things or interventions that a patient can, a pharmacy or nurse or physician can do is lower that infusion rate. Don't let the nurse may have other patients to go see, but your rate needs to be the right one for you. You don't need to be rushed through a treatment if it's going to cause these side effects. Administer IV fluids, and that's one way to do it. Another way to do it is not, we do this a lot, but hydrate yourself. In other words, days before, starting 48 hours before your infusion, start drinking water. Hydration is really important. But a lot of times what we'll do is also give you fluids at the same time, and other pharmacies will do this as well. Give you fluids at the same time you're getting your infusion, or immediately before it, to give you a better chance of not having these side effects. And again, that's most everybody, but some people have, everyone has unique aspects to their presentation. Some people need fluid restriction if they have heart disease. So, definitely talk about all this with your physician, but that's something that's commonly done. And then with more severe side effects that are bothersome, but still you need your Ig and people just kind of struggle through it for 3 days, 4 days, we can give corticosteroids like Solumedrol, a low dose, and it'll help prevent those side effects. If you continue to have problems, sometimes it's good to switch from one brand to another. And I didn't mention this earlier, but there's about a dozen different brands of Ig therapy that really are all the same thing. They're just made a little bit differently. And because they're made a little bit differently, one brand you may be able to tolerate one brand better than another. So we'll sometimes switch. And then if you can't tolerate IVIG at all, it may be good to switch to subcutaneous, like we said, that has much fewer systemic reactions. That's often a really good strategy, maybe to talk to your physician about if you just can't tolerate the IVIG, but it's benefiting you, but the side effects are bothersome. Next slide, please. I think this may be the last slide. And I'm going to do this quickly because I kind of just talked about it. Basically, there's dozens of brands, different manufacturers. Their formulations are a little different. Over the years, they've gotten so much better. So we don't have, like, for example, we don't have sugar stabilized products, which were what was really caused 80% of the kidney problems. So they got a little bit better, but there are differences, and those differences lead to different levels of different impurities and other components of the characteristics, I guess, of the solution, and those can affect your side effects. And so your pharmacist or someone knowledgeable, physician or nurse who's knowledgeable in Ig therapy and the difference of the different brands, can look at your clinical picture and choose a brand that you may have a better chance with up front, right? It doesn't always work, and sometimes we might be surprised that the brand that should make the most sense doesn't particularly maybe work out that way, and something else works better. But we'll look at your risk factors, and if a patient does have a risk for thromboembolism or these clots, then there's one brand. There's different brands we can choose. Same thing with heart disease, diabetes, someone's elderly. So, and then some patients really don't have any risk factors and can pretty much be on any brand. And insurances do have a big effect on this. Unfortunately, sometimes we're can be limited by what a formulary allows us to do, but we don't always just accept that either. If we really have a good case why one brand would possibly be more beneficial than the other, we'll make that case to the insurance, whether it's on formulary or not. I think that's it. Is there another slide here, Sherry? No, that's it. That's questions. So hope that was helpful. We'll turn over, I think Jerry will take over from here and turn it over to the panel.
All right. Thank you, James. You did a great job. I really appreciate it. But this is what we wanted. We wanted to get to your questions today. And I think the first question, Lynn, looks like an insurance question. And I believe I know who that goes to.
Oh, yes. Are you ready? Yes. Michael asked the question, does Medicare cover sub-Q or IVIG, either one or both? Would Medicare or my supplemental, which is Humana Advantage, cover the cost? And is there a copay assistance if needed?
So the answer is yes.
Yes.
Both IVIG and sub-QIG is covered by Medicare and is covered through your Medicare Advantage plan. Sometimes we'll look at your Advantage plan, and sometimes you may need to be on IVIG first before you go on sub-Q. We just have to look at the guidelines for that. In terms of your out-of-pocket costs, you can't use a manufacturer copay assistance because that's only for your private insurance. Any federal plan, you cannot use that. But you can use assistance through MSU. They have a great assistance program, and you can also work with the specialty pharmacy you go to. Most specialty pharmacies have programs. They call them either copay assistance, compassionate care, hardship, but most Medicare patients meet the criteria, and they will have a small copay, if any, to pay, but there's a lot that can be worked out to help patients.
Okay.
And, a beautiful thing about CSI Pharmacy and Michelle's department is that you don't have to be a patient or a client of CSI to access help. So, Michelle, I don't know if you want to put your information in the chat, or if you still do that.
I can do that, and that is so true. I am available to help any patient who needs assistance. And so you definitely don't have to be a patient of CSI Pharmacy to get that assistance. And I'm going to include both my email address and my phone number. So if you have questions, you can get in touch with me. And again, I am there to help the community in any way possible.
And when she says that, she means it.
Yes.
I guarantee you.
She will work to help you. Okay, next, we've got a lot of questions also in the chat, but I've got a short list here, so I'll just keep going on the Q&A because these are coming in as they were asked. Eddie asks the question, will this help with inclusion body myositis?
James, you want to take that?
Yes, I mean, unfortunately, it's not a great answer, which I know it's difficult for the inclusion body patient group. Typically not. It likely goes back to what we started with as far as being antibody mediated versus other causes, but typically not used in IBM. We've seen it very rarely in those patients. Honestly, I think it's maybe been 2 patients over the years. It's patients who had dysphagia, but they also, the physicians thought maybe they had some type of hybrid myositis, but typically it's not. It's covered. It's used more in dermatomyositis, polymyositis, and necrotizing autoimmune myopathy.
Okay. And I just ask our Chief Science Officer, Manuel Lubnis, to comment on this because he also has inclusion body myositis. Manuel?
Yeah. I do have IBM, yeah, and I think there have been some studies, but not so many on those. I mean, we know that some patients claim that it has benefits for dysphagia, so that's what most patients have actually been using it for that. We really don't know if that's a placebo effect or is something else, but at least that's what we know. Certainly, we know from other studies that it has not seemed to benefit patients with IBM for one reason or another. So not common for IBM to respond to that, but I think that's much as that. Maybe we can have more studies in the future, but right now we don't have any more data on that. Thank you.
Thank you.
And that's a great question, and it is a great answer. And it is there is a document about IBM dysphagia on our website, a study that was done that had a list of helpful things that people could do. And I know that Ig therapy was one of the options for that. So if you're experiencing dysphagia, talk to your doctor, not only about Ig, but definitely about the dysphagia, because that can be so dangerous.
Absolutely. I would just underscore that can be very, very serious and should never be neglected.
Absolutely. And I would like to see if we could ask this next question and get some involvement and see what Jason and Melissa might say to this after the panel.
Okay.
If this therapy works, when will you notice successful results? So James, Michelle, or Roxanne, if you want to start out, and then we'll turn it over to our patient experts.
I mean, again, each patient is different in how they react. Some patients will say they see a difference sooner than later, but I usually say give it a good 3 months for it to build up in your system to really see the effects of it. What do you think, Roxanne and James?
Usually my standard answer to that, which I will also qualify like Michelle does, is very patient specific and very individualized. My standard answer is a lot of times we'll see trials for 6 months. After 3 months, if we're not seeing a lot of benefit, then we get kind of doubtful, but a lot of physicians will do a standard trial for 6 months. Some people do experience benefits early, even after the first infusion, several weeks after the first infusion. Roxanne probably has a lot more experience in actually dealing with patients and them sharing their response.
I would definitely say that I agree. It's definitely patient specific, but I always encourage my patients to be patient with the therapy and just stay positive with it too, and let it do its job. So, but definitely within 3 months, I agree with both James and Michelle. If you're not seeing results by then, we would start to think maybe it's not the best treatment therapy, but it's patients individualized to them. And I would say a lot of my patients, though, tend to see some sort of benefit within the first couple of treatments.
Yeah, you know what? I asked my doctor that same question the very first time I had it. And, like Michelle said, it varies. Everybody's different. For me, I did the first 5 days in the hospital with inpatient rehab. But I really saw, for me personally, a major within about a month, because I do it every 2 weeks. Originally, it was supposed to be once a month, but then I had one of those lovely bad reactions. So I've been doing it every 2 weeks, going on 6 years.
Thanks. Melissa?
Hi. So in the beginning, when I first, because I've done IVIG on and off a couple of times due to insurance switches and losing my job. So when I initially started IVIG, I did not see any improvement at all in the beginning. And then when I stopped and restarted later that year, I actually seen improvement that same day after the first infusion, because when I arrived at the infusion center, I wasn't able to, because they, of course, at the infusion center, they have the reclining chairs, and I wasn't able to push that out when I initially got there. The nurse had to help me. But after my infusion, I was able to push it back in and get up out of the seat myself. So I initially seen that win in the beginning, but far as to see a significant win, I didn't notice that until around 3 months, where I was able to do more things around my home. But so that's when I noticed the difference.
That's terrific. If I could just take a quick 30 seconds to add to that, because as I thought after listening to Melissa and Jason's answer, if you think about it, what we talked earlier about, those antibodies are causing that damage. When we're giving IG, you're just keeping them from doing more damage. So there's a little healing process, right? So it makes sense, I think, what we're hearing from Melissa and Jason, what we've heard from other patients. The other thing I want to say quickly is Michelle is working on, because I think it'd be great for us to partner with MSU on this, and I just thought about this, but she's working on a assessment tool that measures some of the ways patients are responding so that we can look at it over time. And so that might be a great thing. I'm sure Michelle's already thought about it, to work with MSU on to help us look at what those questions to be in that tool. But that was a great answer.
Call me.
Yes.
Will do.
Patient-centeredness. It's what it's all about. Lynn's on fire, I can tell.
Oh, yeah, right. Okay.
I have a comment on this one, because I think from what Melissa said, one of the issues with IVIG, sometimes it's messy, right? You start with the treatment, you lost your job, or the doctor cannot schedule you, and then you lose that treatment, and all of a sudden you are like waiting another 2 months or 3 months to restart again. So it's really not like what the doctor would like to do, but it's messy out there, and you have to change things, and you may end up doing something else. So I think that's important to actually work with the pharmacy on this one. It's a very serious issue.
The next question is, are there any recent studies for sub-Q and dermatomyositis? My insurance denied my use for 3 appeals and finally had to do an external appeal, and it's only for 3 months.
The GI.
The GI. Yeah.
Trying to come up with proof of STI.
Okay. The board. Okay. And dermatomyositis. I'm also an RN, and I just totally butchered that, Alicia. So if you want to raise your hand and ask a follow-up on this, feel free. Does anyone want to take that?
Well, there are definitely studies that are published about subcutaneous Ig use for dermatomyositis. There's also a clinical trial going on for a brand of sub-Q Ig, Hizentra, to hopefully get an FDA-approved indication for dermatomyositis. So I'm not sure why your insurance denied it, but a lot of the reasons that insurance denies it is what we send to the insurance company. So besides sending your clinicals, we also, and your history, we also have to send a great letter of medical necessity with those journal articles to really fight the fight. And so once you finish that, reach out to me. I'm more than happy to look at that. There may be a way to start a new claim with your insurance to try to get it approved.
The next question is from Lisa. I told my doctor that if I ended up on IVIG, that would be 6 hours for 5 days. Is this common time frame?
Generally, the first dose that we see is very common to go over 5 days. And that is a larger dose generally, but smaller doses per day. So I would say on average, those are going to last probably about 3 hours. Now, your maintenance dosing generally is a little bit of a smaller dose and over 2 to 3 days. And those are probably on average around 4, 5 hours. But again, it's very patient specific depending on its weight base. So that's how we calculate what your safe rate is going to be. And then also your dosing. So there's a couple different factors that factor into that. But on average, I would say a little, not as long as 6 hours, but 4 to 5 on average, I would say.
Yeah, to that point on the initial infusion, a lot of times with myositis, we're looking at 2 grams per kilogram, which is the larger end of the spectrum of the dose. I mean, it really is. I've seen higher doses, but not much. And sometimes that'll continue every 4 weeks. And so we'll see it for 5 days. And at that time, we're really judging how you tolerate it. Our belief in standard IG standards, we really don't want to give more than what's called 1 gram per kilogram per day. So for most myositis patients, even if they do great the first 5 days, we'll put them on infusion every 2. They'll still get over 2 days every month instead of just in some of the other diseases, we might give it over 1 day. But with those largest doses, we don't like to do more than that, more than 1 gram per kilogram in a day.
Okay. Melissa, Jason, you have some comments on this?
I know for me, originally, the first dose was over 5 days. They went really slow. And so they told me it was going to be a while. And, I think it was about 3 to 4 hours a day. Right now with me doing it every 2 weeks, I've gone from 90 grams down to 60. So I was doing 2 days. Now I'm just doing 1 every 2 weeks, but that still goes about 5 hours.
Melissa?
Yes, I do treatment every 2 weeks too, and it takes me about 4 to 5 hours because I do the pre-meds. I get the Medrol and I get the IV fluid, and I take Benadryl and Tylenol, all of that good stuff before I infuse.
Okay.
Why don't we take a live caller? Caller, are you there? How about you, Cam Beats? What would you like to ask today?
So I'll try to make it pretty quick. My question is to I guess to everyone, but the pharmacist in particular. I'm 22 and I've had dermatomyositis for about a year now, and I've been on IVIG for 5 months. Before that, I was relatively healthy, but with really, really severe chronic migraine and epilepsy. And the one biggest challenge, IVIG has been incredibly helpful, but it has made the migraines so bad that it's almost made me want to quit and just go to Rituxan, even though it's helpful. And I haven't been able to be in school because of my dermatomyositis, but I was a neuropharmacology major, and I talked with my neurologist, so she added on a push of IV Toradol, and Benadryl and saline, and she's considering a bolus of Keppra. Is there anything you can recommend to give during the IVIG to really knock out or prevent migraine?
So the interventions she's made so far are exactly what we'd recommend. What I would say there, and then again, this is definitely a conversation with you and your neurologist. Migraines can be tricky. If you have migraines, you're definitely at risk for them having more severe migraines with IVIG. Ways to mitigate the risk would be lower doses more frequently, kind of what I think it's Jason does, can help kind of prevent that. What I would really like to hear your physician's opinion on, again, not knowing your specific case, what does he or she think about subcutaneous IG, where the risk of migraines are negligible? I mean, much lower risk. That may be a good option if it's something that could work for you.
Thank you. I'll bring that up. I didn't even know about that. Thank you.
Yeah, and insurance is falling. They've been behind, but they're catching up now, where a lot of them will cover sub-Q IG for anything that IVIG is covered for. There's some that we still have to kind of go fight. In your case, we've got a really good fight because you've had benefit from IVIG and had problems tolerating it. So we have a really good reason to say that you should do well on sub-Q IG.
Thank you, Kay, for your question.
Michelle, I saw another question that I think was interested for me. It's like, do they have different approval rates for insurance from different brands of IVIG, or is kind of all fall into the same category?
So I think the question was, do they have different categories depending on the brands of IG? Outside of formularies, not really. The same criteria works for any brand of IVIG, although some insurances are going to say you have to use X brand first. But some insurances, sub-Q IG, can be more difficult to get approved. I think, as one viewer has already stated, to get approved for autoimmune disorders, dermatomyositis, or any of the myositises. With some payers, you have to know how to take the fight to them. I do believe it's going to get better at time. There are studies, but in general, one brand, unless it's a formulary issue, you qualify for one, you qualify for the other.
Lucy's up next on the Q&A, and her question is, I've been on IVIG for 10 years. Doctors tried to decrease it until I'm off of it. After 2 IVIG decreases, I had a bad flare. Now I'm back to 2 days in a row every 4 weeks and doing well. How long can one be on IVIG? I'm scared that of not getting IVIG because I do so well. My current doctor wants me off of it. This is a story we've heard many, many times too. I'm sorry to hear that, Lucy. I know it's very upsetting. So who wants to take that? James?
Yeah, I can take that. Patients can be, there's not a time limit to being on IG. We have patients who've been on it, in some cases for 15 years. Of course, again, this all between you and your physician. When you think about it, it's something that really only works short term, and it goes back to the way we talked about at work. And it works because when you get the infusion, it's so long as you have it in your system, it's neutralizing those autoantibodies and protecting you from them. But it only stays in your system. The half-life's like 3 or 4 weeks. That's why you have to get it every 4 weeks. And so it is something that unless something happens with your disease where it becomes more control, or I can't think of the word I'm looking for, but it's much better control that you can wean off of it and still be fine, then that's great. A lot of patients do have to stay on it long term. I'm not aware of any long-term adverse effects other than the standard risk you get.
Thank you. And I just want to quickly jump in because I wanted to be sure that we spent some time covering some tips for preparing for IVIG and side effect mitigation. I know that there's I know Jason and Melissa, being on the therapy, probably have found some things that they want to share. And then if we could follow up with the beautiful people at CSI and see what else they would like to share on that topic. Does that sound okay? So, James went over some of the common side effects like the headaches and things like that. And I know that we talk about this in our support groups a lot. Hydration, making sure you're getting enough hydration day before, day of, things like that. Jason or Melissa, whoever would like to start, have you found any good regimens that work for you to help you mitigate those?
I think for me, I'd have to start with the hydration. Because when I first had it at home, it was like over a 3-day period, even though I was drinking a lot of water and everything, I still was severely dehydrated and ended up in the hospital for 4 days. Which is why now they do have me doing I was doing a bag of hydration before and after. Now it's just before. But a couple things that I've tried is I will always have my cup of coffee in the morning. But after that, I will do like just ice water, or I make homemade iced tea. Another thing I like to do is get because there's no sugar in them, the Crystal Light packets. But water is huge. I've tried like coconut water. It's not really for me. I can't do coconut water. But for me, the biggest thing is stay hydrated. And if you're not feeling good, let your nurse know. And a lot of times it is the fact that the rate is up too high. And by lowering the rate, yes, it's going to make your infusion a little bit longer, but it's going to make it a little bit more tolerable. I am constantly drinking water, so I'm pretty much always hydrated. But if you don't, yes, start a day or two before. Start getting that getting that water in, because another thing that also helps is if you have to have, me personally, I have a port, but I started out with a PICC line and they had to access my veins. Not being hydrated doesn't help that either.
It's true.
But a lot of people will do broth and like coconut water and stuff like that. But for me, it's just my cup of coffee in the morning, and I will stick with iced tea or just plain water throughout the day.
Thank you, Jason. Melissa?
Hi. So I used to do the water and I would still get the headache. So now I do this. I don't know if you all can see this, but it's kind of like the electrolyte powder where you put in your water and it hydrates you supposedly more than water. And I noticed this has helped me tremendously with the headache. So instead of me just drinking plain water, because I'm always drinking water, during my infusion, I always put this hydrant. It's like a electrolyte booster into my water, and it helps me. It takes the headaches away. I don't have them after my infusion. So like I said, I get IV fluid and I do a slow rate, and I still wind up with headaches afterwards. But when I do this, I don't have any headaches. So, and then two, I noticed in the beginning when I was doing my infusions over like 5 days, I didn't experience any headaches. But now that I'm doing my infusions at home, I only do it once every 2 weeks. And so I can't really, and like I said, I don't have the headaches anymore when I use the hydrant in my water, because I can drink water days before my infusion and even after and during, and I would still wind up with headaches even after I have the nurse. I apologize. I have a 4-year-old. So, so lucky me, you all. And now all of a sudden she wants to go to bed when I come back here in the room. But anywho, so yes, so hydrate. I think is the biggest key. And like I said, sometimes you need more than just plain water. That would be
Thank you. Yeah. Thank you, Melissa. That's great. Great advice. There's someone who asks, how much should you? And I guess it's like, if you think you've had enough, you probably need to be drinking more. So hydrate.
I just wanted to turn it over to the CSI team to see if they have any other tips that they would like to include.
But just to add to what they said almost exactly what I would recommend for my patients to do. I would say a lot of times if patients aren't tolerating their infusions with what they said, we will decrease the rate, which Jason mentioned. And then also, sometimes patients can't tolerate the full dose that the doctor wants them to have in a day or two, or maybe even 3 days. So some of our patients need their infusion, no matter the dose, over several days, or sometimes we even see skipping a day. So again, it all goes back to you're the patient, you know your body and how you feel, and listening to your body and communicating that with your nurse. And that way we can tailor it to specific to you and what's best for you, the patient.
I can knock out one of the questions and this answer at the same time. So I know we're kind of talking about headaches and how you tolerate it, but I mentioned one of the severe side effects is being thromboembolism or clots. And someone asked, does the doctor test for that, whether or not you'd be at risk of that? That was Robin. And what I can say is that our answer to this can actually affect that if you are at risk. So generally the physician, to answer your question, the physicians, there is a blood viscosity test, but I'm not sure it's really would be used before you had IG, that a physician potentially could use, but honestly, I don't think that happens commonly, or it would even make that much sense to do it. Really what we look at when we think you're at risk, it's things like obesity, inactivity, high blood pressure, previous incidents of having like a DVT or a thromboembolism. Those people would be considered at risk. What you can do if you are at risk for thromboembolism is give a lower dose more frequently. As Roxanne said, a lot of times you'll see a day put in between. Jason has some side effects, and so it sounds like Jason, instead of getting his full dose once a week, he's getting it every 2 weeks, and those things really greatly help because you're not getting it all at once. And it's the fact that you get such a high dose of proteins at one time in your blood that causes a lot of these side effects and risk, like thromboembolism. So don't think outside the box, lower dose more frequently. You're still getting the same dose every month. Patients have done really well on that. And don't forget about subcutaneous IG. If you can't tolerate it, I think I saw someone mention that in the questions as well. It's like, I want to give up because my migraines are so bad. Talk to your doctor and say, hey, have you thought about using sub-Q IG? There are a lot of studies. We can share the studies with you that we have. I haven't sought for recent ones lately, but I've had a lot of studies that we've used to get approval in the past that show the benefit of sub-Q IG with lower side effects like migraines.
Oh, wow. Thanks, James. I appreciate that. I know that years ago I had several strokes that they associated with IG because they couldn't find another reason for them. And IG was working for me. And so what they did was they switched me to sub-Q, less of a risk. And I did very well on it.
There is thank you for saying that, because there's a warning, thromboembolism is a warning that's in the package insert for IVIG, but it's not there for sub-Q IG for that reason, because the risk is much lower. Yeah.
Right.
Actually, I got that backwards. It is still there. It's renal failure that's not there. But yes, but it's still listed in the package insert, but yeah, thought to be a much lower risk because of the lower protein levels.
Why don't we go to the the live? Gustavo, welcome. What would you like to ask?
Hi, good afternoon. Here in Southern California, I was diagnosed with NAM, necrotizing autoimmune myopathy, just this past February. I was giving the IV IG my first dose in April. It took 5 days. It ended April 10th. After that dosage, I didn't really feel any improvements until week 2, week 3, week 4. And then along came week 5, and I was trying to get a hold of my doctor to find out if we could start another IV on there, but wasn't able to get a hold of them until this past Tuesday. I just want to know, is it for those that have this and have maybe gone without it for more than 4 weeks? Does your body revert back to how it was? Because I was very weak before I started, and now it just seems like I'm going right back, like I went in reverse. So I did have some improvements, but now I'm reverting right back.
Yeah, I mean,
James,
we talked about this. Yeah, James talked about this, that the immune globulins only last in your body for probably about 3 weeks. And so by week 4, you start feeling it wear off. And so the longer you go without your therapy, you are going to revert back. And that's why we see people getting it on a regular basis every month to replace those immune globulins. So you definitely need to talk to the doctor.
Yeah, I finally got the doctor to prescribe it for at least several months in a row. So at least 4 months. But I was just, because my doctor informed me that he said that, well, he wanted to see how it worked after 6 weeks, to see if it did some improvements. And I was like, wow, after week 5, the beginning of week 5, I still had some improvements, but after that, I just felt like it went rapidly downhill. And I don't know if that's the case.
No, I think it makes sense. And just like Michelle said, it's because the levels have fallen off. And so now the antibodies are back doing damage again. And we see this very frequently. A lot of physicians will give one dose to see how you respond. And then we're not always that good at getting the next repeat if you are responding well. So I think you did the right thing. And I would advise you that if you continue to do well, if he writes it for 4, or he or she writes it for 4 months, but month 3, call up and say, hey, I only got one more refill left, doc. Almost like it's your blood flow, or ask your pharmacy to do it. The pharmacy should be doing it anyway.
Yeah, usually, do you do in-home, Gustavo, versus?
I was so weak that I couldn't get out of the house, so they did offer in-home, so they did come to the house. Yeah.
Yeah, and I think that's another wonderful thing about IG therapy is the ability to have it in home. You don't have to go. Well, Michelle, is it true that is everybody able to do in-home now, or are there still some insurance companies that won't?
Most insurance companies actually will want you to do either in home or at an infusion center. They do not want you to do it at the hospital because it's the most costly site of care. I have not seen a insurance company not cover it in the home. I think that there's misinformation out there that sometimes people think that you have to be homebound, which you don't. So if you do hear that you're not covered in the home, then I would question it, definitely, because you should have almost all sites of care available for you. And that's the wonderful thing, to have choices.
Yes, thank you. Gustavo, did that answer your question, my friend?
It did. I plan to attend next Saturday's support group too, because there's a whole new ballgame for me. I've never been in, never experienced this. So I'm 59, and it hit me like a ton of bricks, and I'm just going through a tough time with this thing.
We're here for you. We're here for you anytime. Please follow up and be sure that you join us for those support groups. Believe me, you'll get a lot out of them. Look forward to seeing you there. All right, Lynn, Manuel, any other questions?
Question from Elliot about COVID antibodies. Would you like to talk about that? His question is, do the antibodies actually help keep COVID away? And is this a normal thing for IVIG, the IVIG?
You can have it, Michelle, if you want.
Is the question, are there antibodies, COVID antibodies in the IVIG?
Yes.
That what?
Yeah.
And do they help?
So we've been, and I've been getting this question a lot. And so I wish I can get an answer that tells us that we can measure it and we know for a fact that there's a lot of antibodies in there that's giving you protection for COVID. We don't know the answer to that, but we do know that we're collecting plasma from people who have had the infection or who've been vaccinated. So in essence, there should be antibodies against COVID. But again, we don't know the true how many antibodies are in there that would give you protection. So again, talk to your doctor about vaccinating.
Yeah, I've had conversations to follow up on that with manufacturers, with their medical science liaisons. They 100% know that there's COVID antibodies in Ig. However, they're not in the least bit confident that it's enough to provide enough protection.
Great, thank you. Appreciate you answering that. And Robin, her question is home infusion as safe as an infusion center? And I don't think she's referring to COVID, but more so safety for the infusion is what I believe.
Yeah. So site of care apps. So I think it's again, it's individually dependent, and that's what we love about patient choices. For the most part, home infusion is safe. For patients who may need closer oversight, the physician may say, really, I want them to be in my infusion suite, getting this in front of me, and maybe that's related, to a more serious risk factor. But the great majority of patients, home is safe for.
Right, because the nurse is there for the entire infusion.
That's right.
They are there for the whole infusion. We've seen, there are some doctors who would like to see a patient get their first infusion in an infusion center that is monitored by a physician. So it may be a hospital outpatient infusion center, just in case there's a bad reaction. Other than that, all the precautions are there. Roxanne, do you want to address anything?
I just would like to add that the nurses in general are all specifically trained to give this drug. So they've been taught what to look for, and we do carry anaphylactic kits should there be an emergency. And so in general, it is safe.
And a lot of people form beautiful relationships with their home infusion nurses. So I know that I did. I had a very special one many years ago, and I'll never forget her, spending 8 hours a day, 5 days a week with her. 5 days a month, I'm sorry. Well, it looks like that's the end of the submitted questions. So I would love to give everybody an opportunity to any final words or advice or tips that you might have. And we can start with Manuel. Anything that you would like to add or say?
I think the only thing I say is now we have the IVIG. I think it's a great therapy, and I think what we learn from people like Jason and Melissa is that actually you can do it. You can actually succeed at doing it. I mean, currently, I suppose it's not the first line of therapy, but I think it seems to be work very well for patients that benefit from it. So I'm glad that we had this session because there are many questions related to it. And I think our friends like Michelle and James are going to help us with the approvals, which is the biggest thing, always is a big barrier. So hopefully we can get that done. Thank you so much.
Thank you, Manuel. Lynn?
I don't have any thoughts at all. Brain dead, I guess.
Not a one.
No, not in one. Other than we love our partnership with CSI. They do wonderful things, and they're very, very specifically patient focused. They'll take the time that they need to help you out. And the work that they do, as Manuel says, is things that we can't even begin to help with. Yeah. So bravo, kudos to CSI.
Yes, and thank you, Lynn and Manuel, for helping me with the moderation. Michelle, any final words?
I just want to stress from my perspective on the insurance side that there's no patient that should be denied coverage for IVIG or even sub-Q Ig for dermatomyositis, polymyositis, necrotizing myopathy at this point. We have a great advancement with Octapharma getting Octagam approved by the FDA for dermatomyositis. We're seeing more copay assistance programs by the manufacturers. There's one from Octapharma. There's Pfizer has also a program that's available for myositis patients. And then, of course, MSU, which I've never seen another organization support the patients like MSU with doing a copay assistance, which helps all the myositis patients, which is phenomenal. So if you're running into those difficulties, something's not quite right with something that's been submitted. And so reach out. Definitely let Jerry, Lynn know that you're having a problem. They'll get in touch with me if you don't get in touch with me directly, and I will jump in and help, because it really shouldn't be that difficult.
Thank you, Michelle. We appreciate all the work that you do for the patients and the caregivers. And Michelle also has an IVIG, SCIG Facebook group. If you're on the therapy, join the group. She provides wonderful information there. So we'll jump around a little bit, and I'll turn it over to Melissa. Do you have any final tips or words?
Yes, I just wanted to, because I experienced IVIG and the sub-Q treatment, and me personally, I had a bad experience with my nurse because during the time I was receiving the sub-Q at home, and I actually had 6 sites that I had to place up under my skin. And it was very difficult for me because of my range of motion, because I was in a flare and everything. And once my nurse trained me on how to do it, she felt as if she didn't have to come anymore to my home. And I used to ask her all the time to come because I didn't have anyone home to assist me, because, when you do, for those who never had sub-Q, you have to rotate your sites. You can't use the same sites. And when you're doing sub-Q, you're doing it weekly. Well, in my case, I was doing it weekly. And so my available sites became limited because, like I said, it all depends, too, of how much medication you're receiving. And I was doing the Hizentra. And like I said, I had 6 sites. But anyway, I had a bad experience. And then, so I just want people to just consider that if you decide to go to sub-Q from IVIG, because I did not experience any side effects. The headaches I did not have. I will say that it was awesome, but not being able to place the needles, and like I said, I didn't like that either, to be honest with you. I had 6 sites I had to stick myself, and that became painful over time. But I didn't have the side effects, in which that was good to me. It was worth it. But but I had to switch back over to IVIG, and during that transition, I lost care, far as because it took so long to switch back over and get it set back up. So I went into a flare. But just long story short, just be mindful if you are currently doing IVIG and you want to switch over to sub-Q. Just, be aware that if you don't have anyone home to assist you with your sites, you want to consider that far as with your nurse. Make sure you emphasize that, because the nurse that I had, once she trained me on how to do it, she didn't feel the need to come back to my home. And that was just not an option for me. So, but that's all I had to share.
Thank you, Melissa. And I'm sorry that happened to you. And it is important to know that, if you're not getting the care you deserve, to make sure that you contact the company to let them know. Roxanne, did you want to respond?
Yes, I just want to apologize that you had that experience. It hurts me to know that was the experience, but I did want to just let patients know, if you are on sub-Q, for us, if you don't have the help that you need, we still are going to send a nurse for you. So I encourage you to advocate for yourself, like Melissa said, that you do need that extra support because they should continue sending a nurse. If sub-Q is right for you, I think that you should still have that nursing help that you need.
Yes, thank you. It does hurt, doesn't it? Did you have, we'll turn it over to you for any final words or tips that you might have.
I don't have anything extra to add. I would just like to thank you all for having me today. I really enjoyed this. So thank you for having me. I look forward to doing it again.
Oh, thank you so much, Roxanne. We look forward to having you back with us. Jason, do you have any quick closing comments or tips that you want to share?
All I have to say is, you know what? If you guys start, if you're not on it yet, don't look at the bad things that you're going to find online. You know, Dr. Google's not your friend, not all the time. But I have been lucky with the fact that I've gone through New Factor for the last 6 years. I've had the same infusion nurse. I've had the same lady calling me for the last going on 6 years. So it's really nice to get those type of people in here. You know, I've gone, unless I was hospitalized, every time I've had my infusion, it's been at home. And I've had my problems before when I was going with my PICC line. Ever since I had my port placed, I've had great experiences. But never be afraid to ask questions. You are your own best advocate. Ask your questions. Let your doctors and nurses know, hey, this is how I'm feeling. This is what's going on, because they need to know.
Absolutely. Thank you so much, Jason. And thank you and Melissa both for joining the panel. Now over to my good friend, James. Do you have anything that you would like to share?
Well, no, thank you. I'm going to take the opportunity to answer 2 questions I found, just because I got a little bit of time here. So clinical indications, Terry asked for initiating IVIG. I'd say talk to your physician. Insurances sometimes will approve IG specifically, especially in dermatomyositis. They're going to want to see things like muscle biopsies and everything your doctor did to diagnose you, and maybe that you've tried some other drugs as well, but not necessarily. I do not know of IVIG interacting with gabapentin to answer that question. Someone's having a horrible time because they're being forced to use a specific pharmacy. I think that is horrible. Sometimes we can do it through the medical for people like that, but not always. You could always talk to Michelle if you wanted to look into that. Finally, Lena asked if any studies were looking at effectiveness of the different brands in necrotizing myositis. And not really. We, from those in the industry and IG clinicians, generally feel like all the brands are equally effective. It's just they have different kind of tolerability profiles. In the end, they all have the same amount of IgG, which is what's really making you better, but they have other things that can make you sick. But really enjoyed it. What I would say that support groups like this, MSU is wonderful. Learned so much, and so much about what we've learned at CSI has came from patient support groups, like this one being one of those, where it's really the more you get to interact with patients, the more you understand what's needed and what you're missing. And Melissa, absolutely, it's easy to get on these things and sound like sub-Q IG is good for everybody, but it's not. It's a good thing we have choices. But again, thank you for your time. I really enjoyed it.
Thank you, James, and thanks for taking the time to answer those last few questions. And we told you how wonderful these people at CSI are, didn't we? And I think would be remiss to not focus on spotlighting Kitty Cat. We love animals at MSU. We're all like just huge animal lovers. What's your kitty's name?
Oh, Jasper.
Oh.
Little Jasper.
What a cutie.
Yes.
What a cutie. And what a great way to end the webinar today with a picture of stroking your kitty. Thank you, Roxanne, James, and Michelle for joining us today and for just answering our questions. You know, it's amazing how patient-centered, and you know, these CSI is out in the community. They're not just sitting behind desks all day. You know, they're out in the community working with patients too. So I just love that, and I love you all, and we thank you for your generous.
We love you.
Yes, we love you, and thanks for joining us today. And feel free to stick around for another couple minutes. Lynn, Manuel, do we want to run through a couple of things that are happening? Okay.
Yes, we do. Got some exciting events coming up, and we're going to contact you, CSI people, about some exciting news on our pain publication and FDA listening session. So you'll be hearing from us too on that. So.
Yes. So we let's see. Coming up would be the next thing. Coming up would be the Fireside FDA chat, right, Lynn?
Fireside FDA chat, where we sit down with the 8 wonderful speakers that spoke about the burden of myositis to the FDA. Several departments there. We had about 36 people from the various FDA departments, and they did a wonderful job. It was a wonderful learning for us. I mean, we laughed, we cried, we bonded as a team. And so what you're going to hear is the behind the scenes. We're not going to talk too much about the closed session because it is closed. But we will be doing a summary that will be put out on the public FDA site. But basically, it's a story about what we learned from being in close quarters together, working on creating this story about the journey with myositis. And I think we each came away with something different. And most of all of it is associated with the power of our voice and what we can do as advocates to advocate for ourselves and the rest of our community in many ways. So that's next Wednesday.
That's on Wednesday.
Yeah.
Sorry.
Yeah, that's Wednesday. Next Wednesday from 3 to 4 Eastern time. And then on the 31st, we will end Myositis Awareness Month with a fireside chat with the team that brought you the pain paper, which is the announcement is coming out tomorrow, was just published in Rheumatology Journal. And we'll talk about a retrospective look, yay, at how it came about. It was a call to action from our community based on the CDC guidelines at the time for pain medication. And we wanted to establish a marker in the ground that said that for people who didn't believe that there was pain with myositis, well, yes, there is. And now it's official. So we're going to talk to the team that brought this pain study up, and that would be Jerry and Emily Fillmore, who conceived the study. Manuel and I didn't do much of anything except push it to the doctors who wrote it. And you're going to have the opportunity to talk to our favorite doctor, Dr. Salman Bai, who is our medical advisor, and our new research partner, Dr. Abi. We call him Abi Hashim, from Massachusetts General, who were he was the principal author, and Dr. Bai was co-author of the paper. And they're going to talk to you about what it means for the community, the implications of this very first research study on pain and opioid medication in myositis patients, what it means for the community, and where we go next with our plans for research. And they will also be there to answer questions on pain. So we're really looking forward to that. It's an exciting time for us to have this published. And we hope you're going to be able to get a free copy of the paper. We'll make that available tomorrow in an announcement. And we hope that you'll download the paper, read the paper and then bring your questions to the fireside chat, and they'll be answered.
Excellent. Thank you, Lynn. And there's also another one. We also know that May is Mental Health Awareness Month.
Yeah.
And as part of our mental and emotional health, on May 26th, this is open to anyone here and all myositis patients, care partners, CSI, you're welcome to join. But it's a workshop with Lori Wong, who is living with inclusion body myositis, and that's on Thursday, May 26th from 6 p.m. to 8 p.m. Eastern Time. And it's a workshop that's going to focus on emotional well-being, providing simple evidence-based steps to support your mental well-being is just as important as the steps that you take to care for your physical body. So check out our website. We have all of the details to register. All of the events that Lynn just mentioned are on Zoom. They do require registration, but they are free as always. Thank you again to CSI Pharmacy. Much love to you guys. Enjoy the rest of your day, and we look forward to seeing you next time. Thank you.